Hello. Today I have the honor and pleasure of welcoming with me Dr. Kshitij Nair. Kshitij, I know him from last many years during his post-graduation days, now senior resident. Thank you, Kshitij, for coming here.
Thank you so much for having me, sir.
So, Dr. Kshitij, I am into teaching and training PGs in psychiatry in India, and now I am glad to have you with me in DAMS. So, first of all, what was your experience during post-graduation? Where did you do from, and how was it during first year, second year, third year?
As you know, I joined during the COVID era. So for the first 6 months or so, both patient exposure as well as patient exposure was quite less. So as an advantage, we got a lot of time to read. So I don't think my experience will be very easily generalizable to the current this thing. But I would say most of my learning was from my ward rounds, for example. The questions that were being asked, like we had to prepare and go for that. Plus, of course, whatever you learn for exams, etc. Another thing that I did, which I would recommend also to everyone, is that during my towards the end of my second to my third year, when I was relatively free post thesis and everything, I also tried to attend and participate in as many inter-college, whether it be quizzes or paper poster presentations. Sometimes just there are these scholarship opportunities that you get. You can write an application and they may give you a scholarship for some conference or the other. So I try to explore as much as possible, at least within the country, what all is going on. Heard a lot of people talk about their experiences, about their specializations, and that I think gives you a sort of perspective as to how what all is going on in the branch. What are the different aspects to different sort of subspecialties and all of those. uh, so that also adds to your learning experience. So when you're talking to or when you are going to read something, that this is something that practically is useful. Maybe even though it's not something that I see in my hospital or practical or whatever, but hey, this is useful in the real world. So that is something I would recommend in addition to what everyone does.
Hmm. A new first year resident joining psychiatry within the first 2 3 months gets a little overwhelmed with the subject because of less exposure.
Right.
So, a first year PG who has just joined MD psychiatry, what is your message to him?
So as you said, my message that I always tell anyone who joins in first year or is thinking about joining psychiatry also is that you are going to feel extremely overwhelmed for the first maybe 3 to 6 months or so, and that's perfectly normal. It's okay. Psychiatry is not something that is taught in any amount of depth. I feel in our MBBS curriculums, even for your NEET PG, it's a small subject. You don't really read about it in a lot of depth, and there is a lot of things there are a lot of things in psychiatry that you have no idea about, which you need to know to even understand basic things like diagnosing, managing, what to talk about, what to ask a patient, what to write in your history, and that takes some time, right? And this is true for a lot of other branches also. I have friends who are in derma, in radio, etc.
Hmm.
Those subjects which are less focused on MBBS, they also go through the same thing. But at the same time, don't be overwhelmed, definitely, but at the same time you also have to be diligent in those first 6 months. The basic structure that you form in those 6 months is what will carry you through the rest of your MD. If you have a good grounding of your basic neurosciences, your basic phenomenology, your basic diagnostic criteria and what all they are, even if you don't remember it completely, but conceptually at least you have some understanding of it, then the rest of your residency will be relatively easy compared to the first 6 months.
So, how should a resident start studying during first year? I mean, if he is starting to study, what should he study first?
So what I recommend to my first years at least is that our three big books, right? One is our Fish and Sims, which is two books, but I think of it as one, like phenomenology. That is Fish and Sims. Second is your diagnostic criteria, whether it whatever you follow in your institute, whether it be ICD or DSM or whatever. And third is your theory part, right?
Hmm.
Theory part also is again in two parts. One is your basic theory, which you will probably start with synopsis, and second is your basic pharmacology, which you can whatever is followed in your institute, some study from Stahl, some directly go to Maudsley just to get an idea of what is given when, etc. Up to you. But I would say that over the course of these 6 months or so, diligently daily on a daily basis try to read at least one topic from each of these, right? You are not going to remember it, that's okay, This is something that you'll have to keep coming to multiple times throughout your MD. But diligently try to read at least one thing per day. Right? Today, maybe you decide that I'll read Delusion from Sims and Fish. Fine. Next day, you read something from, say, Synopsis. Right? Doesn't have to be tied together in any sort of comprehensive. I will start from this subject, like start from this and go in the order of the index or anything. You can just choose whatever you find interesting or whatever you saw that day, whatever somebody asked that day. But diligently do it, like at least for 6 months. You daily read one or two topics from here and there. It won't take a long time, maybe an hour, maybe 2 hours or so, apart from whatever clinical work you have to do. But I would recommend this. And second is that uh, there is a lot to read definitely, but books can only take you so far. Right? A lot of psychiatry in terms of diagnosing, in terms of talking to patients, in terms of getting patients to open up about certain symptoms, and a lot of things that are missed out. Right? You will often have this experience that patient told you 3 4 symptoms, you take it, present it to your faculty or to your senior resident or whatever, and suddenly the patient will say 5 more symptoms. Right? So this is not the. I think the most common reason for this is that they have learned to ask questions in a certain way that patients open up to them. Just like in surgery, we say that something that is very important is the amount of cutting that you get, right? The amount of actual handwork that you get to do. Similarly, in psychiatry, the cutting part of psychiatry is talking to patients. Right? Spend as much time as you can, whoever is admitted in your ward, not just for the purpose of, oh, I need to come to a diagnosis, or I need to write this workup, or I need to fill these headings inside my workup, but just learn to talk to them, how they are feeling, what is going on in their lives or whatever. That is a skill that you build up. You can't really be taught that, right? And that skill will only develop if you practice. So that is again something I would recommend to all first year, second years, whatever. Whenever you are in psychiatry, this is something you should do diligently.
A very important point you raised, that I said patient said 5 symptoms in front of me, but in front of the teacher or the senior, he said 10 symptoms, because they have a way to ask, which you learn. Just like you learn good surgery from seeing a good surgeon operating. Do you think the role of anybody else examining a patient in front of you and you being a trainee helps?
Right, definitely. This is also, as sir rightly points out, this is something I always recommend, that don't just work up your case, present it to your faculty, senior, whatever, and go away. Also see how they elicit history, how
Yes.
they talk to the patient. Uh, ask your seniors that, I could not elicit this, say, whatever, delusion, phenomenology, whatever, and ask them to, when they are eliciting it, pay attention, like carefully. Don't just zone out, ki, yeah, they are talking and they'll come to some this thing. The way they talk, the language that they use, how they reach a point for the patient, that is very, very important. That is something you learn only by experience, as well as by experiential learning as well. Right? So that is something quite important, I think.
Another question students ask where when I talk to resident is, when should they start studying psychology? Or if I would modify the question, do they need to read psychology during MD in first year?
So, very grossly in psychiatry, there are two aspects of psychology that we need to learn.
Hmm.
One is your clinical psychology aspects, such things like memory, cognition, learning, motivation, theories related to that, which directly apply to your day-to-day MSc, etc. Right? You need to know what memory is, what abstraction is, because these are components of your MSc that you need to ask daily.
Mhm.
So the better your theoretical grounding of it, the better you can assess as well as judge based on what people are saying, that is their cognition intact or not. Cognitive psychology, I guess you could call it. Another very important part of psychology that is relevant to our practice is the personality aspect of psychology, right? This also involves all of your, ultimately it also involves all of your therapies as well, whether it be your psychodynamic therapies, cognitive behavioral therapies, etc. All of it sort of stems from basic personality understanding, that these theories say that personality is structured in so and so way. So when there is a disruption in the way that they interact with the world and with other people, we use so and so framework to fix these things, right?
Mhm.
So that is again very important to learn, because although initially your approach may be guided through something like, say, the ICD or the DSM, right, that if they meet certain checklisted symptoms, then this person has, say, bipolar disorder or schizophrenia or whatever it may be. Right. Gradually, as you get to know more and more psychology, the more you talk to patients, the more patients you see, you realize that not a single person in psychiatry ever presents the same. Right.
Mhm.
One person's mania will always be different from another person's mania, and the nuances of that, why, how this person differs, um, symptomatologically as well, in terms of their interaction with their family members, all of it ultimately forms a core part of your treatment plan. That you need to understand the person you're treating if you want to treat their symptoms. And in that, psychology helps a lot. Like, psychology provides multiple frameworks that you can help to understand the person. When we talk about, say, pre-morbid personality, for example, in fact, the longer you are in this field, the more you realize that PMP is probably one of the most important parts of your MSc. Initially, when we were taught, it was more or less ki, these headings are there, you try to fill it up, may or may not matter, unless it's a personality disorder, of course. Right. So personality aspect of psychology is also quite crucial. So these two aspects you need to sort of balance. Like the second one, the personality part, you can probably delay a bit once, by the time your grasp on other concepts is good enough. By the time you learn to talk to patients properly, because that requires a lot of interpersonal skills as well. But the cognitive psychology part of things, I think you should learn at least by the end of your first year. I feel. In fact, it is part of paper one, I think, in most structures.
Any source that you recommend to read this stuff? What is the best source according to you? From where?
So for the cognitive aspects of psychology, memory learning, etc., I went through a lot of books. I didn't really like them much. The Barron and
Morgan.
Morgan and King, for example, I did not like those books a lot. I know a lot of people who like those books as well. I think you need to find out what you like. I used a book by Wayne Wheaton, called Aspects of Psychology, or something like that. The book was by Wayne Wheaton. You can search for it. It's a very colorful book as well. I like the way things were written in that. I found it easy to understand in that. But in general, now that you're in a postgraduate field, I think it's hard to say that this one book is recommended. Of course, you will have to go through multiple and see what suits you, what kind of writing, what kind of style of presentation. As long as it's a recognized book, it shouldn't be some random odd book that you're picking up. So these options are there in psychology. Plus, a lot of psychology aspects you can also watch through videos and all online, because psychology is not entirely a medical field, right? There's a lot of videos on YouTube, etc. You can watch of people who are specializing in this since ages, like about learning, about memory, and all these things. And in today's world, of course, resources are endless as long as they're uh, appropriate resources, they're scientifically valid resources. You can read from those as well.
You mentioned about a theory book. According to you, in the theory book, synopsis, Oxford, Ahuja, or CTP,
Right.
what do you think is most useful for the resident?
So I think synopsis is a good starting point.
Hmm.
I think most faculty who have spoken to all have the same thing, that synopsis should be like thorough by the end of your PG. Like if you are not able to answer something, or you don't know something that is written in synopsis, then examiners tend to be a little not so confident in passing you, at least theoretically, on theory basis. So I use synopsis in terms of I had already read quite a lot of synopsis in my before my PG, because I was always interested in psychiatry. So my psychiatry SR had given me a soft copy of it, so I had read through it a little. So that's a good starting point. Oxford textbook of psychiatry. There's a shorter Oxford textbook of
Mm-hmm.
psychiatry. I think that has a similar role to synopsis. So either you can use. For the detailed parts of theory, people have different opinions. What I would recommend is that if you want to learn it from one source, like, so I am somebody who likes to read the same thing from multiple sources. So I usually tend to read some paper or the other from here, some article or the other from here. And instead of reading one thing multiple times, I like to read multiple sources of the same thing. So that is an option. You can always just go on, say, Google Scholar and just type key neurobiology of schizophrenia and search for, click the thing for review articles, and you will find recent review articles about it, which will summarize a lot of things. And there'll be multiple papers, so you can, whatever you understand best, you can do. If you want to study from one source, and if you want to study from a textbook, I would recommend either. Then I would recommend the large textbooks. One is your comprehensive textbook of psychiatry, CTP. I think the 11th edition is out now. So that is the, I think, most recent textbook that we have. Lishman also, I think, came out last year or last to last year, the
Mm-hmm.
latest edition. So that is also very good. I've read that also. I found it quite nice. When I was in my PG, the new Oxford textbook of psychiatry was the latest textbook, so I had studied from that. That also gives a very good, I mean, it's much shorter than CTP. It's much more to the point than CTP. CTP also tends to go a lot into history, sociology, or those aspects. So I would say if you're studying CTP for the first time, skip out on things which you think are not relevant. Otherwise, you'll end up wasting a lot of time reading things which are not so relevant to you. Right. So read CTP with some amount of filter in your mind. But I would definitely recommend that the major disorders that we have, like common disorders rather, not even major, like say schizophrenia, bipolar disorder, depression, at least once or twice you read it from CTP by the end of your third year before going to give your exam. For these major illnesses, at least, I would recommend reading it. Drugs also, I found CTP to be a very good source about medications to read about.
Mm-hmm.
The summarized versions that they have are quite good, I feel like. If you want to read pharma in more detail, then I think stars is the starting point for pharma, like synopsis would be for rest of the theory. But it's not a book I am a big fan of because I think it oversimplifies to a great extent, and it is difficult to directly apply it to practice. There's a lot of variables about practice that are not really that detailed in stars. So I think CTP is a better intermediate option. If you are interested, if you want to read more, then the APA, that is American Psychiatric Association textbook of psychopharmacology is there, which looks very intimidating. It's a very thick book, but half of it is irrelevant, half of it is clinical listing that you are already reading from CTP or whatever. But the parts about the drugs themselves are quite well written. Disorder wise, what kind of dosing, what kind of side effects can be expected, what is approved, what is not approved, along with the pharmacology part of things like kinetics, dynamics, and all. It's very well written, I feel. So I think that is also a book that is worth reading in your PG. But if not, at least CTP drugs part is quite comprehensive, I feel.
How much psychotherapy exposure doing yourself during post graduation is important? Have you done yourself some cases?
So I had taken on patients of my own interest with some seniors who were also interested in psychotherapy. So that definitely helps. But most institutes I know don't really have a very structured psychotherapy program, even though it is an NMC recommendation. So that is one of the variables I would ask you to look at before selecting an institute. Do they have a robust psychotherapy training framework? Um, you should know some basics of it, at least some basics of CBT, some basics of psychodynamic therapy to for any patient interaction. You can't really cut it off from your psychiatry practice, even if you're doing a private practice, because you will want to spend time with patients, and patients will also feel you'll be able to retain patients more the better you're able to understand them, the better you're able to counsel them. In fact, a lot of patients come also saying, we just want counseling from you, not that we want medications from you. Right? So both are necessary also to a practice, I feel. Some people have a sort of natural charisma that they can utilize. If that is there, then great. You may not need that much of psychotherapy grounding. But some therapies I feel, such as the basic principles of DBT, for example, there are a lot of distance tolerance modules, chain analysis, what to do if somebody is self-harming. ERP is something again which is quite, has very good evidence also, and it is not that difficult to perform, like if you know enough and if you have some supervision, right? So you can basically, if you even if you open a pure psychiatry private practice thing also, if you know these small things, then you can give it in sort of micro doses to your patients. They also feel happy with that this part the doctor really understood, and this thing that he advised I'm able to do, and that will stem from your knowledge of psychotherapies. So it's great if you know it as well. MET, again, motivation enhancement, is also quite crucial. Any interaction with a patient of substance use disorders, you need to know the basic principles of MET for normal interaction also.
How much, according to you, is the importance of research during MD? Like, one is the thesis paper that you do. Any other paper have you done apart from your thesis?
So I am not a big fan of research. In fact, if you were to ask my opinion, I would say you should scrap the thesis also in MD because you're forcing children to do research where they may never really feel interested in it. Low quality research is being put out. The research is definitely very important. I think it's your personal decision. If you are very interested in it, you should pursue it, you should do it. Wherever you are in a training institute, your faculty is probably doing some research or the other. That is the basic norm of being a faculty. So you can always look for opportunities, learn from them, do whatever you want. I have students who have I have PGs right now who have done systematic reviews also during their PG itself because they were interested in it, to be fair. I am personally not a big research oriented person, but whether you know to do research or not is one thing, but you should know to understand and read research well at the very least. That is something you should nurture in your PG, because beyond this, beyond even up till PG, you can probably learn from textbooks or whatever. But once you cross the threshold of PG, suppose a new drug is released or some medical rep is coming and telling you that you should prescribe this, and they will give you a paper. See, you can see this paper; it is very effective. You should develop the skills to be able to read that paper critically and decide for yourself whether something is good or bad. And you should also learn how to keep in touch with research, even if you are in a non-academic setting. You should always be in touch with whatever is going on, because especially in psychiatry, it is a very, very, very rapidly developing field. Every other month or 2 3 months, there's some or the other breakthrough that is happening at this point, at a very basic neuroscience level also. So it is always good to keep in touch with it. So I would recommend that at least learn the process of reading research, if not doing research yourself.
Another question that a student asks is, what is the importance of specialty posting during MD? Like some colleges during MD, they post students for child psychiatry posting in NIMHANS, geriatric psychiatry posting in KGMU. Did you have such posting during your PG days?
So in our setup, we were posted. I think most colleges in Delhi do get posted to IBHAS here.
For what duration?
1 month, I think, at least is.
How was your
prescribed.
exposure there?
So it's definitely a different this thing, because I did my MD from Safdarjung, which is a GHPU setting, general hospital setting. So in IBHAS, you see a lot of forensic psychiatry, something that you see a lot of in IBHAS. The closed wards, semi-open right now it's called, I think, semi-open wards, the asylum setting, of the olden times, that you get to see a lot in these postings, basically IBHAS. Plus IBHAS in Delhi at the time, I think maybe even now, has the only separate maternal and child unit. So I was personally interested in child psych, so I went into that as well. So I got to see a lot of, although children you see everywhere, but there you get to see a lot of these medico-legal cases with children also, CWC cases and all of those also. So it's definitely a good experience. Of course, the better institute your college is sending you to, the better your experience will be. I think from AIMS Nagpur, we had sent our PG to NIMHANS for child as well as for forensic, I think. So that is a great experience if that is part of your training as well.
So do you recommend institutes to have that experience? I mean, they should have that specialty postings.
Sir, I think in your MD, this thing, you should get an exposure of whatever aspects of psychiatry are there. So then you can make an informed decision as to what you want to go towards.
So it helps in deciding the specialty also.
Yeah.
And how much is neuromodulation exposure important during MD?
Same, I would say, sir, because neuromodulation is quite up and coming now. Almost at least in tier 1 cities, it has become quite common. I mean, RTMS specifically, I'm saying. TDCS is also becoming more common now, because that is even easier to do. You don't need a setup as such, you just need a small machine for that. MECT I won't comment on, because I think most colleges, I think that's an MD requirement that your college needs to have ECT. So that I think everyone is exposed to. But TMS, TDCS, I would definitely recommend that you should get some exposure in your MD. Exposure as in not just learning how it works and learning how to do it, but also some experience, so that you are able to counsel patients that I have seen this works for so and so types of cases, for so and so types of presentations. How long does it take to work? What side effects are there? All of that you come to know once you worked in that setup for some time. So I would say maybe even if it's just for 10-15 days, you probably should get some exposure in this as well.
Okay, last and the most informal question, Dr. Kshitij. Residents of psychiatry feel that when they are working in a GHPU setup, they are meeting residents of other departments, medicine, surgery. You must have had several encounters with them, and their opinion about a psychiatry PG and the way we deal with patients often disturbs a young psychiatry postgraduate. They get disturbed, they get less recognized. Has it any of this happened with you, or do you feel that anything should be done about it?
Sir, I think this is a common story for any GHPU setup you work. On the one thing, it is good, you make friends across branches, you make friendships and beyond also across branches. It's always a possibility. But I think the more common experience is that you end up fighting with a lot of other departments.
Yes.
Right, for referrals or for whatever. What kind of referral have you sent? Why have you sent this to us? Is not our concern. Whatever, like झगड़े होते रहते हैं जैसे भी
Hmm.
है. uh, I would say don't take it very seriously because other residents are also under immense amount of stress.
Hmm.
You are not going to be whatever, however much you argue with them, you are not going to either change their minds also, neither are you going to change their years or whatever of biases they have. I think the best you can do is be friendly with them despite how rude they are, so that they
Hmm.
get a this thing that maybe this is somebody I can go back to and talk to.
Hmm.
Maybe maybe they are the ones who need help, like, which is
Yeah.
true compared to psychiatry. Somebody say in OBGY or medicine or surgery is probably under immense amount of pressure,
Yes.
and they
So
will
we
be,
have to understand that.
yeah, we will have to be a little understanding of that, no matter how much pressure you
So
are
do
in.
you think this is a routine
It's a part of
residency
GHQ
training?
postings, I feel, in
So
general.
according to you, our residents should not be disappointed if you are not treated the way you expected
Yes.
by other department. Thank you so much, Dr. Kshitij. It was wonderful talking to you, and I'm sure this podcast has given insights into the MD psychiatry training for the resident. Thank you so much.
Thank you so much, sir.